Hello everyone, my name is Joanny and welcome to Love Qualified. I am a second year physician associate student training in London, and today I'm going to be telling you guys all about my pediatrics placement. So if you haven't seen my previous videos where I talked about my geriatric medicine placement, my obstetrics and gynecology placement, and my mental health placement, I will leave my playlist down below, so my PA School Vlogs playlist down below, so you can watch and see what experience I've been having and what I've been learning so far on my secondary care placement. So my pediatrics placement was my fourth placement, and it was in a different hospital. So it was in a hospital that was much further away than the hospital I did my first three placements in. I actually had to wake up at 5:30 in the morning because we had to get there for 8 o'clock. I was so tired by the end of it, like so exhausted. It literally exhausted me. I was not looking forward to the commute because the commute took about an hour and 20 minutes, so I had to take the tube. But one good thing about the whole experience is that I was not alone. I was traveling with my placement partner, and she was a very good company. We got along so well. We did everything together. We went in together, did things together, left together. So yeah, we just encouraged each other throughout those 3 weeks, and I was so blessed to have her. She was amazing. She was an amazing person to talk to and just to pass time with. The long tube journeys. So yeah, I was just so blessed to have her. We got there for 8 o'clock in the morning, and when we got there, like, the hospital was a lot different to the ones I was used to. And one of the striking things about the hospital is that they still write notes by hand. So the hospital I was in my first three rotations, everything is computerized, everything's electronic, and then I had to go back to writing things down in like proper notes and stuff. So that was a big difference between the two hospitals. But another thing is that the pediatrics department, the ward that we were in, it was just one ward, so it was a general pediatric ward that we were based in, but you had the pediatric A&E as well, which was separate. So when we went in there, we noticed like the ward was just so like, the environment was just so different. The nice drawings on the walls, like drawings of animals, lions, zebras, monkeys, like loads of different drawings. It was so colorful, like everything on the walls was so colorful. Even in the bays themselves, like the curtains were filled with animals and stuff, and just drawings of animals. And you had a play area as well, where the children who could play could come out and go and play, and their relatives would be there with them. And so that was really cool to see the children playing. And you had another room as well, which was like a stimulation room or something. You had like lights and stuff like that, and some children would go there. I think maybe children with maybe autism and stuff like that would go there, and so that was really, really cool. You had people who used to come and play piano, and they would play the cajon and just sing on the ward, which is not something that you see on in adult wards. So they would come and sing songs. And also you had a lot of decorations, because on our final week, it was like December, it was the first week of December, so the nurses went crazy. They put up like loads of decorations all around the ward. There was a big snowman, and so many things hanging from the ceiling. It was great. Like, I really love the environment. I really love being there because I love colorful things. So it was nice. The environment was really nice, and I could you could tell why they do that. It's because it's the children, not adults. So it was very like cheerful and all of that. So that was really good. So we turned up there for 8 o'clock, and the night team handed over to the day team. So usually it's the registrars that were covering the wards, and they would hand over all the patients to the day team. You usually had a attending consultant for each week. So you had an attending consultant that would be there from Monday to Friday on the wards every week, and then you had registrars as well, and then you had the F1s and SHOs as well. Mostly F1s and SHOs, and GP trainees, a lot of GP trainees as well, part of the team on the ward. But you also had the teams that were working in A&E overnight. So the pediatrics A&E, the registrar would come and hand over as well to the patients, so they knew what was happening. You also had the daycare center, where it was kind of like ambulatory. So children who had come in who needed who were still on antibiotics, but they didn't need to stay in hospital for those antibiotics. They would be discharged and then they can come to daycare and get these antibiotics, or if they had to come back to do some bloods to monitor their some markers, they would be discharged home and then they can come back. And so they had daycare, which was separate, and then some of the consultants and the registrars as well, they had clinics throughout the different days of the week. You had some registrar-led clinics, registrar review clinics, and some consultant clinics as well, because some of the pediatric consultants were also specialists in different things like endocrinology and all of that kind of stuff. So the ward we were on was the general pediatric ward. So obviously you had pediatric surgeons, which were separate, and then you had the NICU as well, which was the neonatal intensive care unit, and the other intensive cares, which was separate from this general pediatric wards. That's what happened. And so after the handover, sometimes we had teaching. Not every day of the week, but I think it was Thursdays we had teaching, and the doctors were really nice. They welcomed us because they'd had PA students before, so they were expecting us, but they never had 2 students before, so they were really happy to have two of us. And from the get-go, things were so different because everything was handwritten, and peds is a very specialty. They have their own guidelines, they have the way they do things and the way they document notes as well. So for the first few days, I think we just observed, and we asked the doctors to show us how they're documenting the notes, so we can be an actual so we can actually help during the ward rounds. So they had the ward rounds during the day, and they usually split some of the patients between the registrars and the consultants. The attending consultant for that week, he or she always saw the new patients, and if all the patients were old patients, like patients who had been there, if there weren't any new patients, then they would just split depending on the patients that they knew. So that was what happened. So we asked the doctors to show us how to do the documentation, and so we were scribing when the consultants went in or the registrars went in to see the patients. The rooms so you had the side rooms, and then you had the actual, and I think you had 4 bays, like 4 bays, A, B, C and D, and then you had a lot of side rooms as well, because a lot of the children that had come in, the babies especially, had come in with like respiratory tract infections, and a lot of the babies had RSV, so respiratory syncytial virus, which caused bronchiolitis. So it was bronch season this year, so bronchiolitis. So RSV, the virus, usually, I think there is usually an epidemic like every 2 or 3 years or so, but I think this year it was really high, because almost every baby in that ward had RSV positive bronchiolitis. It was ridiculous. Like the very first week, all of them were on oxygen, on CPAP, on this and that, and some of them were really ill. But then going on to the second week, I think we started seeing other conditions apart from respiratory tract infections, because obviously it's not a ward just for babies, it's for all children. So you had I think with peds, like sometimes you forget that it's not just about babies or toddlers. Peds covers children from 0 years to I think 16 years or 17, so you have a wide range of ages of children to look after. We helped out with the ward rounds, we scribed, so things are kind of different when you're writing, when you're scribing. So we prep the notes before the ward round. You just write what the age of the baby, if they're male or female, what they were admitted with, their background, their medication history, what medications they're on, the diagnosis, or what they've been diagnosed with, any investigations that they've had. So if you had results for blood tests, chest x-ray, you would write that down. Their feeding history, so how they've been feeding, if they're exclusively breastfed or if they're feeding on solids, how they've been feeding overnight. You can usually see that because the nurses document on the same notes as well, so you can write that down, and also just how they are really, and their observations as well, you would write that down. And then after we'd prep the notes, we would go in with the consultant and see the patient. You would write how the patient is currently. Usually the parents are there with the patient, or like most of the time, all the time the parents are there. And the side rooms especially, or even like on the wards as well, they usually had like beds, so beds that the parents could sleep on, which I thought was really good. And you could stretch out the beds, and then when they're leaving, you push it back up and it looks like a wardrobe, but it's not a wardrobe, it's a bed. So yeah, I thought that was really good because it provides the environments for the parents to stay over and look after the child. So I thought that was good. So yeah, we would document the examination findings, and because it was handwritten notes, we could actually draw. Like, I learned how to draw. They taught us this in at uni, but I hadn't actually had the chance to practice it because the hospital I was at, you do everything electronically. So you just write, for example, chest is clear, no crackles, or wheeze bilaterally and stuff like that. But in this hospital, because we're drawing everything out, because we were writing everything out, you could draw things out. So instead of saying crackles, blah blah blah, you could draw out the lungs itself, and then you would, for crackles, I think you would put like X's and stuff, and then for wheezing, you draw musical notes, and then and for the abdomen as well, you know, stuff like that, and the heart as well. Heart sounds normal, heart sounds 1 and 2 present, vowel sounds, abdomen soft and non-tender, and stuff like that. So that was really good. And then we would write the plan. So what the plan would be, you'd write out the plan for the patient throughout the day. So that was good. And that was what usually happened in the mornings. And so the ward rounds usually went up until 12 or 11-ish. And then we usually had loads and loads of things that happened in the afternoon. Sometimes we had like safeguarding meetings where we talked about we would use like a case, use like an example of a case, and then talk about some safeguarding concerns. I only attended one of those meetings. That was usually on a Friday, and that was really, really good. I got a certificate for it. I learned so much about like how to spot non-accidental injuries in children, and how to be able to be aware of when a presentation could potentially be, you know, domestic violence or domestic abuse. So yeah, so I thought that was a really, really good session that I had. Usually the meetings usually last for about an hour, so that was a really useful session. And then some other times you would have like a complex case meeting where they would talk about complex cases, so all the different consultants would come in, and sometimes you had the juniors as well. But because we were students, we were staying for every meeting so we could learn. They would talk about all the complex cases that they had, and they would get like feedback from a help from their colleagues, and figure out like what to do and how to treat the patients, which I thought was really, really cool. And so yeah, we had a lot of these meetings, and sometimes they would just review like patients who had been in their care and who had passed away, unfortunately, or patients who they basically to carry out like a reflection of cases of things that did not go so well and things that could have gone better. So they would have meetings where they would meet and they would discuss these patients and just talk about it and get like learning points from it. So there was a lot of reflection and stuff like that, which I thought was really, really good. And I loved like sitting in those sessions. Sometimes they went on and on and on. Like when we didn't know the patients, it was a bit sometimes it was a bit boring, but I did learn a lot, and my placement partner as well said the same, that she did learn quite a few things. So yeah, and then that's how we usually spent our mornings. So we did the ward rounds, and then in the afternoon, sometimes we stayed on the ward and helped out with jobs if it was really, really busy, helped the doctors do jobs. And other times, so we would usually, after that, we would have lunch. So we'd have lunch, me and my placement partner, and then we would go to A&E, so pediatrics A&E. And so we had the chance to actually clerk patients ourselves. So I've learned a lot in A&E because it gives you an opportunity to, you're the first person that sees these patients, you clerk them, take a full history, and then we went and presented the patients to the registrar or consultant, and then the consultant registrar goes and sees the patient again and examines the patient again, you know, just because we're students, just to make sure that we didn't miss anything, and then they'll come up with a plan, and then we'll do all those things. So it was a really good learning experience. In A&E, I learned a lot. We had a patient that came in with headaches. We had a lot of patients that came in that had sickle cell anemia, so they're having a sickle cell crisis, so they're coming with pain. And then we had a baby that came in with jaundice. Had another baby you had a lot of babies that came with fevers, coughing and wheezing, and you know, lots of things like that. And then just across the A&E to the other side, I think you had the resus. So babies who were really, really unwell would come in, and then they would see them. The consultants would see them, and if they needed admission, they would see the patients there and treat the patients and make sure that they're stabilized and stuff like that. So some of the conditions that we saw during that first week, like I said, RSV positive bronchiolitis, we saw a lot of those. We saw a patient who had liver failure. and also ulcerative colitis as well. In the second week, there was, remember how I said we had teaching sometimes? There was a teaching by one of the registrars. He was talking about purpose and the process of our work. He was talking about how we find our purpose, what the purpose of our work is, the work that we do as healthcare professionals. And he was talking about the fact that we measure our success by, say, for example, waiting times, not breaching waiting times, patient satisfaction, some other things that we use to measure our success and stuff. But then at the end of the day, that's not the real measure of our purpose, you know, whether patients are not breaking breach time or not getting complaints, stuff like that. So the real purpose of our work is to help people, you know, as cliche as that sounds. Really, the reason why we are put in the place that we are is to help people. And you know, we meet people in a stage in their lives where they're most vulnerable, you know, and so worried, especially the parents as well, because the thing with pediatrics is you're not only dealing with the child, you're dealing with the parents as well, you know, because the parents are the ones, you know, that need a lot of reassuring. The babies are usually, you know, the children usually are very good fighters. Sometimes they can deteriorate really quickly, but other times they can get better really quickly and just turn around really quickly. But the parents are the ones that need a lot of reassuring, is to keep them going. So you're dealing with, you know, at least 3 people or at least 2 people. So yeah, so we talked about the fact that we are there to help them, and that is the purpose for our work. And that's just in a nutshell what he said, but I really liked that teaching. I thought it was really good, just a good way to think about things, think about why we do things, why we're in the profession that we're in. And I think in the second week as well, they were in a state of emergency and they had to close down A&E because there were so many unwell children there and they didn't have enough beds on the ward. So usually patients are coming to A&E. If they were going to be admitted, they would send them up to the ward, or if they're really unwell, they send them to HDU, or if they were well enough, they would send them home. But there was one time, I think one day, where the children in A&E were really unwell. A lot of them were using the respiratory support, and they had to close down A&E and say no one could come in because they didn't have any beds. So, you know, that was really scary, you know, because sometimes you think about the fact that you have to turn people away because you don't have enough beds and you don't have enough resources. A lot of babies were on CPAP, which is continuous positive airway pressure, the machine that helps to the babies to breathe when they're in respiratory distress. So they'd run out of machines, and HDU, so high dependency unit, didn't have enough machines as well, so they had to close down A&E. And I thought, you know, that made you really think about, you know, the shortage of resources and staff in the NHS, and just to see how everyone was so stressed about it. It just opened our eyes to, you know, seeing those things in real life. So that was a bit scary, but I think it got better towards the end of the week, so that was good. So I really learned a lot about it improved my history taking skills, like with children. You know, there's a lot more added things that you have to ask when you're taking history from a child or a baby or from their parents. You have to ask about immunization history, you have to ask about their birth history, prenatal, birth history, and postnatal, so how the pregnancy was, the birth, how the birth was, and if the baby had anything after birth, and also things like their developmental history, and also vaccination, so immunization history, developmental history, and social history. You have to ask if there's any social workers involved, if the people at home, like anyone smoking at home, do they have any pets, anyone else looking after the child, just stuff like that you need to like actually ask when you're taking a history, so you get a clear, like, bigger picture. So I really did learn by clocking patients in A&E. I did learn a lot about, you know, these different questions that you need to ask, and also how to communicate with babies and children. I learned a lot about my communication skills, improved a lot. And I think I clocked one patient, both of the baby's parents were doctors, and I was like, okay, no pressure. So the baby had come in with I think the baby had upper respiratory tract infection, and they had sent the baby home and asked the parents to bring them in if he wasn't opening his bowel, if he wasn't passing urine or drinking much. So they brought him back in a few days later because he wasn't peeing much. So I had to go and take a history from the parents, and both of them were doctors. They were really nice though. They weren't those kind of doctors that would kind of like be patronizing or like look at you, especially because we were students. They were really nice, and that was a really good learning experience because they really taught us like what we'd forgotten to ask and stuff like that. It was really weird but it was really good. And we also clerked a patient who had a potential appendicitis. They come in with abdominal pain, and the GP had referred them in because they suspected that it was appendicitis. So appendicitis is one of the conditions that presents atypically in children, so they might not necessarily have your typical, your right-sided pain, and you know, so it was something that I learned. It was a good learning experience for me to see how some of these diseases can present atypically in children, so I learned a lot from that experience. By the end of the third week, it was really, so by the third week we really saw how helpful we were, as we were really like part of the team. So when the junior doctors changed over, because the junior doctors had to change over the F1s, and the F1s moved to another specialty and new F1s came on the ward. So we, as the PA students, we'd been there for 2 weeks, so we knew how things worked. So we were kind of showing the F1s like what to do and stuff like that, and it just showed like us like the importance of continuity of care. And that is what PAs do, you know, on the wards, where we're not like the doctors where we have to rotate all the time. When you have someone who's there for a long time and they know how to do things, it provides that continuity of care. And so, you know, it really emphasized the importance of our role as physician associates, and I thought that was really good, because then we got, you know, the hang of things, and we helped out a lot. We helped them like to do their job and stuff, and the doctors were really good. They were really good with like teaching, and I really learned a lot from them. Every day I had like stuff to write and go and look up and read up on, so that was really, really good. And then I think that was like Christmas time, so we had a children's choir that came in the ward and they sang Christmas songs. It was so nice, like so lovely and so cute. Like I really, really loved it. And then we had some teaching as well. We went for some teaching, so we had some teaching about breastfeeding, the importance of breastfeeding and the differences between giving a child breast milk and formula milk, and how that affects the growth of the baby. So apparently if you're giving a child milk from a bottle, they are more likely to be overweight like later on in life, and they were just presenting like different presenting different research, like evidence and stuff like that. So it was really interesting. We also had a neonatal medicine teaching about some rare conditions in babies or children, like congenital eyelid ectropion and a pantalette or something like that. I don't know, I probably will never hear about it again, but it was just interesting to learn about these different conditions. I met a PA who works in ENT, so ear, nose and throat. I can't remember where she studied, I forgot to ask her, but it was really nice to see another PA. I recognized her because she was wearing her Royal College of Physicians, Physician Associate green lanyard, and I walked up to her, I was like, oh my gosh, you're a PA, I'm a PA student. And yeah, it was just really nice to see a PA working ENT, because I think it's one of those ENT is one of those like specialties, so it was really nice to see a PA there as well, which is really good. We learned how to do discharge summaries, because you know, discharge summaries are kind of different in every hospital really, so it was really good that we could be able to do some towards the end. And some of the conditions that we saw in the third week, we had children that came in with fractures, like femur fractures, humeral fractures. We had a child that came in with periorbital cellulitis, a tinea pedis as well, and also an encephalocele, and also like some teenagers that come in with suicidal attempts. So another thing, you know, the mental health issues that can be seen in teenagers or children, you know, teenagers attempting suicide. A lot of the time you ask, you know, why would you want to kill yourself? Why would you want to attempt suicide? Like, you know, what are the problems that you have that would drive you to want to kill yourself? But you know, children are stressed, you know, in the world that we live in today of social media, and where children are so confused, they attach their identity to so many different things. Children do get stressed, and they do get low and depressed, and they struggle with school, and especially children from homes where they don't have a very functional family. If they're dealing with domestic abuse, domestic violence, they can have all these scars and all these things. So it doesn't matter the age of the person, whether they're a child or a teenager or a grown adult, people do go through things. And so that really opened my mind to that aspect of medicine, where it doesn't matter the age of the person. Children really do suffer from mental health issues, and they need to be treated accordingly. So that was a really good side of pediatrics to look at, and a good experience, learning experience for me. And so the general consensus was everyone was really nice and friendly. The team were really friendly. They just welcomed us in and they gave us stuff to do, and we really felt like part of the team, which was really good. There was amazing support from the staff, the nurses, and everyone. They were really, really good. I would say that before you start your PEDS module rotation, definitely go over your notes, and also look at the common conditions that present in children, and especially atypical conditions that present differently in children and in adults. So I would say that you should look at those, because that would really help you when you're clerking patients, and also the way you communicate with patients and how you take a history from PEDS patients are slightly different. So I would say go over that before you start your placement. But learn about how you would communicate with children, like the different ages, some tips and stuff. And I think that's something that's a skill that's really important, especially it doesn't matter where you work really, except especially if you want to go into GP, you're going to see a lot of like children. Or if you want to go into PEDS, you're going to see a lot of these children. But if you're working in a specialty that you won't see children at all, then yeah, maybe you don't really need this. But if you're going to work in GP or go into PEDS, then these are skills that you definitely do need. So I would say make sure that you're prepared before you start your PEDS placement. But yes, anyway, that was all that I learned in my PEDS placement. I hope that this video, gave you a bit more insight on what to expect in your pediatrics placement. I'm obviously, like, because the hospital I was in was different, and then depending on when you have yours, you might have a completely different experience. But I hope you've learned something from this video. Let me know in the comments down below how PA school is going for you. Let me know what sort of PA content you would like to see. I will be going back and making more videos, hopefully about to do with PA school application series. I haven't had much time to do a lot of videos nowadays because I've been so busy with placement and trying to get my case history done, my case history deadline and all of that stuff. So hopefully I'll get back to you creating more videos and finish the PA school application series, so that would be complete for you guys, to help you guys in your application process. But anyway, yes, thank you guys so much for watching. I have started my AMU placement at the moment, so I've finished going into my 3rd week now of acute medicine, and we have 12 weeks in that placement. I think what I'm going to do is I'm going to divide it up into 3 sections. So after every 4 weeks, I'll do a video rather than waiting till the end of the 12 weeks. Or I would see, really. I think I'll wait every 4 weeks. I'll do 1 video. So it would have 3 videos for my AMU placement, just because it's so long. But yeah, thank you guys so much for watching. I hope you have a lovely day, and God bless. Bye.